Okay, this is Chapter 6, Abnormal Psychology, Somatoform, and Dissociative Disorders. I'm Professor View, and I am going to go through this slide deck with you, as well as I'll give you some videos to watch afterwards, and you can get more out of the information in the chapter that way. And perhaps some assignments based on that. You'll just check the assignment section on Brightspace. Okay, I'm going to switch it back over here to the screen. So there you see that's the title of our chapter. Somatic symptom disorder is the first disorder from the DSM. One or more specific symptoms that are distressing and result in significant disruption of daily life. So there's excessive thoughts about these things, feelings, behaviors. Any one somatic system may not be continuously present. The state of being symptomatic is persistent, typically more than 6 months. And so somatic symptom disorder is a description of symptoms that are unexplainable, usually to a medical condition. Let's see here. Aches and pains with age. Many people engage in somatization, or a tendency to communicate distress through physical symptoms and pursue medical help for these symptoms. There's an example in your book. Gisela, discussed in the text, makes frequent doctor visits for physical symptoms with no discoverable biological cause. And so this is what you would begin to be suspicious of having a somatic symptom and dissociative or dissociative disorders and the various types. The many different physical symptoms before the age of 30. Symptoms are vague, and a person usually seeks treatment from different places over the years. They also can impair daily functioning. The textbook lists common symptoms. Illness, anxiety disorder. Let's see if we got that one. Yes, illness, anxiety disorder is other people that they may be less concerned with symptoms and overall disease. People with illness, anxiety disorders are preoccupied with having a serious disease, and may explain general bodily changes. Someone with an illness like an anxiety disorder may worry about having hepatitis or AIDS based on minor changes in pulse rates, perspiration, or energy level. You can naturally have worries about illness, anxiety disorders, but excessive worry can become when it becomes a problem. You can especially as we get older, we obviously have more aches and pains, but it's when we focus on those to the extent that it impairs us and there's no real reason for worrying about it. In other words, they don't find any medical connection to it. Doesn't mean sometimes they miss medical connections as well. Conversion disorder, functional neurological symptom disorder. So in a conversion disorder, people actually experience motor or sensory problems that suggest a neurological or medical disorder, even though one can't be found or one is not present. Sudden blindness or deafness, paralysis of one or more areas of the body, loss of feeling or ability to experience pain in the body area, feeling a large lump in the throat, or pseudo-seizures, seizure-like activity, such as twitching or the loss of consciousness while without electrical disruptions to the brain. Psychological, not physical stressors generally trigger the symptoms of conversion disorder. And the greatest, I actually have an example of this. Many of these disorders, for instance, this one is very difficult to run across. They're not that common. in the general population and don't occur that often over time. So I was working with an adolescent male who whose mother came to me and had this symptoms that he was at baseball practice and suddenly had a type of paralysis in one of his arms. He couldn't use his arm, and he also passed out. I think he was up at bat, and he passed out at the plate. And going to the doctor and having a thorough medical examination, nobody could find anything. And finally, they recommended counseling. And so, of course, I counseled him with his mom present first, or at least I interviewed him and his mom. And then I talked to him several times by himself. And he described kind of a typical adolescent life. However, his parents had divorced, and this was in a small community. And actually, his parents and another couple in the same community divorced and remarried each other. So the wife and the husband from one divorce married, and the wife and the other husband from the other divorce married. So they basically essentially swapped wives legally and remarried. And my initial response was, well, it's stress from this, and because we couldn't uncover anything specific in his life. He didn't report anything stressful or anything uncomfortable. And actually, he quit coming to therapy, which is quite often when people don't get any help. I didn't feel like I was helping him. And I later, probably a year or two later, I ran into the parent, and I asked about the adolescent, and she told me that, and I'd known he had a girlfriend, but she told me that he and this girlfriend, she became pregnant, and the girlfriend hid it from the parents, was able to hide it right up until the point that the baby was born. And this young man was keeping this secret. And apparently this caused so much stress that the young man had a conversion disorder, had partial paralysis, had episodes of passing out. He was classic. And I've never run into one since then. So in all 40 years or so of working with people in this area, I ran into one person with this disorder. Now, I may have had other people that had it too, but I didn't know it. So it's kind of hard to, it's difficult to figure that out. And so it's also hard to diagnose. Back pain is one of the most common complaints reported by people with somatic symptom disorders. Factitious disorder. Factitious disorder is I think we used to call this, we kind of lumped this all together with hypochondriacs or hypochondriacs. This, though, however, is a falsification of physical or psychological signs or symptoms, or induction of the injury or disease associated with identifiable deception. So these are actual people that actually know they're deceiving people using these disorders. They present themselves as ill, impaired, or injured. Deceptive behavior is evident even in the absence of obvious external rewards. In other words, this illness, this fake illness, is used in spite of, without any need for it. So it becomes diagnosable then. It's not better explained by another mental disorder. You can also have a factitious disorder imposed on another person, which is previously factitious disorder by proxy. So you can falsify physical or psychological signs or symptoms in induction of injury or illness in another associated with identified deception. Individual presents another individual, a victim, to others as ill, impaired, or injured, and the deceptive behavior is evident even in the absence of obvious external rewards. So these are people who fake illnesses in spite of, without any particular need necessarily. They can have a consequence out of it, maybe gaining something, but they will continue to do it in spite of it. And this slide shows you, again, the falsification of a disorder on someone else, and gives you several of those symptoms that are already listed in the previous slide. And this is a YouTube demonstrating a factitious disorder and malingering, and I will actually make that available for you after the slideshow. I don't think I can make it work here, but we can try. Okay, let's see if it's started. No, it's probably not gonna work here, so I'll make that available to you. Prevalence of major somatic symptom disorder, there's about 0.8 to 4.7%. Of course, these are just difficult to determine since some people will never be presenting with anybody who would keep a record of it. And you can see conversion disorder is one of the lowest, as well as illness anxiety disorder. But however, illness anxiety disorder also is easy. It would be easy to underrepresent in reporting. And there's a slide, I believe was one of the boxes in your textbook on college students. Most of you know the stress that you feel, probably right now in this class, sorry about that, because of the pressures that are being put on you to achieve such a high level of education and numerous assignments, etc. As well as then you have your regular life that you actually do have outside of this. Some people are working a job at the same time. Some people are doing this in their second language, which I personally can't even imagine. I just want you to know we care about you, and then some people may have obviously family issues that come up. Life goes on in spite of you being in school. So it can be very difficult. And some people have stress because maybe it's the first time, maybe they're the first one in their family that's attended college. And you aren't really given the hidden rules of college that some of us had because our parents all had already been there and could have helped guide you. So that could have additional stress as well. So some of those things you can do something about. You can get help, and I encourage you to do that. Don't just sit with your stress by yourself. The dependence on whether anyone reports these depends on on whether or not people on how much stigma is present in the culture usually. In the older days, it was harder to admit you're an alcoholic because you were considered to be a pervert or a sinner, and so instead of having any kind of treatment, they would sort of put you away and dry you out and then turn you loose and wait for you to get messed up again. And you can imagine how much stigma would be on someone with a psychotic disorder. This is another video about stigma. I'll make that available to you. Here's brain, biological risk factors for somatic disorder. The key aspects of the brain thus include the amygdala and limbic system, hypothalamus and cingulate, prefrontal and somatosensory cortices. Other proposed changes in these brain areas interfere with inhibitory behavior and promote hypervigilance about symptoms, as well as increase central nervous system activity and stressful responses. So the the issue around the brain is that I like to use a metaphor that, as far as science goes, in my opinion, we're just barely in the sandbox learning about the brain. We have just begun to actually look at the brain and have used various scanning techniques to watch the functioning of the brain, to watch the changes that happen in the brain. And we shouldn't pretend that we know enough to always know uh, what's going on. Even when you can see something changing, we don't know what that means. So we take it with a grain of salt. But that is the future. There's a great future for people in the biological area because of this. If you can imagine, in the older days, still today, you go to a psychiatrist, you may have gone to a psychologist or a psychotherapist and explained your symptoms, and they referred you to a psychiatrist, which is a specialized medical person. And that medical person has, I mean, I'm not diminishing their ability. They have an amazing history of working with multiple, sometimes hundreds, if not thousands of people. They've seen different uh, symptoms, and they've provided medication for a number of those symptoms that actually has made a difference. So they have a great uh, basket of information they can draw from. But the thing is that always remember that this is the brain that they're treating, and the body that they're treating, the brain especially, is the one organ in the body that we have never really looked at, like you would look at the heart if you thought they had a heart problem, right? But the brain is just, it's sort of like, here, take 3 of these and call me in the morning. It's more like, call me and come back in 2 weeks. But they'll give you an antidepressant and they'll say, come back in 2 weeks, and really they're seeing if it's having a positive effect and the combined negative effects as well, to see if it's working for you. And if it's not, they'll try something else. So they draw on that basket of information, but at the same time, this is one of the medical areas where until recently we haven't even looked at the brain. And even now, the 99.9% of the psychiatrists that you know or would go to don't have a scanner in their office, or nor would they have the training to use one. And it's really relatively cheap. I mean, it does cost quite a bit to have one of these scanners, but if you can imagine using it with over thousands of people, and to be able, and we'll see some things from Dr. Daniel Amen that where he can actually show you some things he believes are areas of the brain that, in other words, things that we never saw before. So I believe, if I might be getting the number wrong, but I believe he's identified 5 different areas of the brain where ADD can be the symptoms, but it can be a different part of the brain causing those symptoms, and the different parts of the brain react differently to the medications. So depending on which kind of ADD you have, which part of the brain that is causing it, would depend on which medication was going to work the best. And so, or treatments, not just medication. So anyway, so that's my little spiel on that. So I just want you to know, even though I'm going to be having you look at a brain model and be able to know those just basic parts of the brain that are presented in your book, it's not that I think that that's the only way to do this, but it's also, we're barely scratching the surface, but I want you to at least have the most basic level of understanding of the brain parts. So when somebody tells you about the amygdala, you know which, you can kind of visualize which part of the brain that is. And you can even print off what I'm going to give you and color it. It's actually a coloring page, so it's kind of fun. And you can learn it that way and see where that part of the brain fits into the system. Okay, let's move on. Here's a brain scan. It's the blood. This shows where the blood is. I believe it's a picture of the blood. Yeah, here we go. It shows the blood flow of people with conversion disorder. Decreased blood flow may occur in areas of the prefrontal cortex and other aspects of the brain related to a loss of sensory and motor functioning as seen in conversion disorder. So you can actually see blood flow. Now, like I said, what does that mean? we're not actually sure, but we know something's going on, because when people in conversion disorder have it, we can see what is going on when that's happening. Environmental risk factors include illness, behaviors such as involve medically related behaviors potentially reinforced by significant others. So your family may actually reinforce by enabling you and feeding into this. Cognitive factors are likely powerful influences in somatic symptom disorders, because many people of these with these disorders use somatic explanations for even minor bodily changes. So it gets morphed into all kinds of different things that they're, I feel a little dizzy. It must be my whatever, my seizure disorder coming on. Causes of somatic symptom disorder: misperception of symptoms, feelings of uncontrollability, feeling like you can't control. For instance, the young man I was explaining, whose girlfriend got pregnant. It's a pretty uncontrollable situation. Watching your parents get divorced and remarried to someone else in town where you know them and their kids, and so that's quite a pretty sense of uncontrollability in an adolescent's life, or any other person for that matter. And then people that pay too much attention to minor bodily changes, that can be causes, so that it kind of keeps going that way. Risk factors: stressful life events, traumatic experiences, and comorbid anxiety and depression. So you have a combination of things that can also cause it, especially in children and adolescents. That might give us information about how to prevent somatic symptom disorders by recognizing that stressful life events, traumatic experiences, unnecessary medical interventions, and comorbid anxiety and depression can also predict that you might have more focus on all these symptoms and why you should get help for people that have those problems. There's a book that I use in some of my classes, and right now it's slipped my mind the name of it, but they describe at the beginning of the book a group of children, a busload of children who were kidnapped by these people that wanted to hold them for ransom. And they had planned this out to where they had the bus. They took the bus. They had a hole in the ground big enough for the bus. They drove the bus down into the hole, covered the hole up so that the children and the parent and there was a couple of adults, I think, with them, were trapped in this bus until they were rescued by the authorities. And this was back in the 60s, and some of the at least the thinking of the time was that those children are just going to bounce back and they don't need any kind of treatment. So for us today, I hope for you would kind of know that might be not the best way to go. Probably not good enough, let's put it that way. So I think that we need to be able to recognize when people need help, and we provide that even in a preventative manner. We use interviews, questionnaires, and personality assessments to assess these disorders, and you can read about that in the book. Here's an assessment: somatic symptom disorder guidelines. Common medications are the SSRIs, or serotonergic, gosh, I can't even talk today. Reuptake inhibitors. Those are the regular old, the good old antidepressants that everybody hands out these days. They're handed out so much that you actually find them in the water supply, because many of the water cleansing techniques don't remove them. Antidepressant medication may help reduce the severity of pain as well, so it may reduce some of the symptomology. And there's some of the medications that are used. I won't go into that. Just so you should be aware of some of these, not because it's a somatic, you probably won't run into it that often, but to know that there's medications available. Again, psychological symptoms are associated with problematic illnesses, like when people get sick, especially chronic illnesses. And so you have it for so long that you start to imagine. I mean, I have a personal experience of this I fell, passed out due to a heart condition. I passed out when I was jogging, injured my neck, injured my spinal cord, bruised it, and it took me about a month in the hospital to learn to walk again. And I'm left with some neurological reminders, let's put it that way. I have the left hand, which is, I call it the claw, just for fun. But when I really think about it, it really bothers me that I can't use it the way I used to. I can't run the way I used to. And so if you focus on those things, what you can't do and how it's affecting you and the pain involved, that I have ongoing pain, chronic pain, mostly just discomfort, it can become a bigger problem than it really is. Seeking a full medical and psychological exam is important. I didn't have any choice. Mine wasn't somatic. It was real. But people that do have somatic, they do need to get medical and psychological examination. And what happens is to help people stick with it and not move around. And what helps also with treatment is that that all the professionals that are working with this person know. So the psychologist or the psychotherapist knows, they communicate with a psychiatrist, they communicate with parents if they're involved, with a loved one if they're involved, and so that everybody's on the same page, and to help the person, not to make them feel paranoid, but to explain to them that we all need to work together to decrease these symptoms, and to recognize what it is. Predictors of chronic somatic symptom, again, the more severe the symptoms of an illness. Females tend to have more somatic illnesses, mood problems as well, depression, anxiety, and unrealistic fears, phobias, or illnesses that are unusual in the first place. It's hard to read slide because it doesn't work the way I've got it set up. So it just, all those slides are showing you as a continuum, and on one end it's not as big a deal, and on the other end it is a bigger deal. Brief episodes of dissociation are common. So you dissociate. I usually use this as an example. You dissociate on a regular basis, sitting in my classroom. That's you dissociate, daydream while you're watching this video. Something has taken your attention, perhaps, or maybe you went off on a tangent on some thought you're having, and then you realize you're not listening, or maybe I'm boring you to death. But you can also have dissociative fugues, which are periods of time where you may forget what you've done over a period of time. Dissociative identity disorder and depersonalization disorder as well. They can be brief disturbances of consciousness. We might think of dreams as dissociative disorders, although Jung would say that dreams are as real as any other thought you're having, any other perception that you're having in the world. It's part of the world that you're perceiving. He's kind of a neat guy to listen to. I'm reading his book. This is dissociative amnesia. If any of you have watched Breaking Bad, he actually has a factitious disorder in there, but he fakes a dissociative amnesia where he pretends that he goes into a dissociative state, and he walks into a building. He disappears for quite a period of time for a whole nother reason, but his is factitious. But I should have mentioned that back at the factitious disorder. I just thought of it. But he pretends to dissociate, but if he really was, he would dissociate and be off walking around and not have any memory of it, and then he shows up in a store totally naked and acting as if he doesn't know he's totally naked. People with a dissociative disorder might also do that and not realize what they're doing. You also might have seen Jason Bourne, the Jason Bourne movies. His character has dissociative amnesia, spends much of the film attempting to figure out who in the heck he is. because he's been programmed to have lost his original personality, and this theoretically was created within him. Jeffrey Ingram woke up on a sidewalk in Denver with no memory of who he was, and they think that he had a dissociative fugue state. And I'll show you a video about that. So this is dissociative identity disorder, DID, formerly known as multiple personality disorder. And DID is when a person has developed separate parts to themselves, and those parts are somewhat or completely separate from the other parts, where you may or may not be aware of these other parts of yourself. We all have different parts of ourselves. We have just integrated those parts into our personality. Well, these folks, probably from severe trauma when they were younger or over a long period of time, develop different places. Basically, you can think of them as rooms in their mind where they can go and be a different person or have a different identity. And there it gives you the basic symptoms. You can have a two-way amnesic relationship, so you can have a relationship where two or more distinct personalities include a host personality, subpersonalities, and often differ in their awareness of each other. So you can have awareness of each other from one direction and not the other, or a mutually awareness relationship. Depersonalization, derealization disorder. This is refers to persistent experiences where a person feels detached from his body, as if in a dream state. When this exists, derealization. With derealization, it comes with a sense of that the surrounding events are not real. So this disorder is described in table 6.10 here. So you have a deep sense of being separate from yourself, kind of detached from your body, like a dream. And then if you also feel like everything around you isn't real, that's the derealization state. Castelli and her art, Judy was diagnosed with 44 personalities. It's common in people with mental disorders. Dissociation is common, although prevalence of formal dissociative disorder in the general population is less common. So it's not very common. I've only heard, I think probably I can recall 2 cases. I didn't work with them, but one of the other therapists worked with a lady who had been at Larned State Hospital, and she had, I can't remember, it's multiple, she had 35 or 40 different personalities that they had found. And sometimes they can discover more. Here's another video about a person. I'll make that present for you. Many people with dissociative obviously feel stigmatized by others, and you can have a negative beliefs from other people. So I won't try to get help or seek treatment, and my treatment will work. My persistent symptoms will worsen. The cause of dissociative disorders remains unclear, but the evidence is biological risk factors may include brain changes in areas most responsible for memory and consciousness integration. It would include amygdala and thalamus, hippocampus, anterior cingulate cortex, and frontal cortex. Hillside Strangler Kenneth Bianchi, he claimed he had a personality responsible for his killings. So quite often, people will try to use this as a defense for insanity. And many times it's factitious. Maltreated child may develop a strong and unified sense of self. So it's kind of like PTSD. We don't know the exact percentage of children, but I know from adult studies that about 60% of the people who experience severe trauma do not develop PTSD. And my guess is that a great majority of people who sev- se- receive severe maltreatment as children do not treat multiple personality or become DID. But we may have lack of trust, obviously, and we know from our book that those things have happened. So we try to prevent, again, maltreatment of children. Here's some sample items from the Adolescent Dissociative Experiences Scale. There's full scales of this that you would learn about in master's level school. You would actually learn what these scales are and how to administer them. So we have medications to target comorbid symptoms such as anxiety and perhaps antidepressant and antipsychotic and anticonvulsant medications. Side effects may cause dissociation. So again, you have to be careful about this stuff and have somebody that knows what they're doing, obviously. That one's one hard to read. Symptoms are often murky, referring to a person for full medical examination. So we need to know exactly what's going on totally with the person. Some people respond positively to biological and psychological treatment. So the degree of dissociation or psychopathology or trauma can kind of predict, but if somebody wants help, we try to give them help, usually, no matter what. But again, just like with attachment disorder children, or children who have attachment disorder, there's a difference. You may approach it differently depending on severity. We have to teach parents different ways to approach these children, the adopted parents, because they're not going to trust and not going to react in a way that normal kids, people that don't have the disorder, would react. So those are some great reflections that we'll get into more in other chapters. I want to thank you for being here.